Good morning, everyone. I'm Dr. Manmohan, Senior Resident in Department of HPB Surgery and Liver Transplant from Mahatma Gandhi Medical College and Hospital, Jaipur. So today we'll be presenting a case. A 64-year-old gentleman by the name of Baldev Singh, who's a shopkeeper by occupation, hails from Alwar, from the state of Rajasthan, came to us with chief complaints of pain, abdomen, more in the umbilicus and the epigastric region for the last 25 days, uh, jaundice for the last 15 days, and vomiting 2 to 3 episodes for the last 5 days. On elaborating the history, sir, uh, the patient's pain originated from the umbilical region and then extended to the epigastric region. It was insidious in onset, mild to moderate in intensity, intermittent in nature. It had no radiation to the back. It was not associated with meals or change in posture or associated with any aggravating or relieving factors. The patient then decided to consume over-the-counter analgesic medicines, which led to transient relief of the pain. Then, during the course of this particular illness, the patient noticed yellowish discoloration of the urine and sclera for 15 days. It was insidious in onset and gradually progressed and deepened. Then the patient also noticed that he started developing itching, which was initially in the extremities, and now currently it had extended to the trunks. Last five over patient also said that he developed gradual nausea, and it was associated with 2 to 3 episodes of vomiting since the last 5 days. This vomiting was not associated with food intake. It was non-bilious in nature and non-projectile. On further cross-questioning, the patient said that he feels constipated and has noticed pale-colored stools since the last 10 days. However, there is no history of fever with chills, no history of abdominal distension, no history of bleeding PR, melena, or hematemesis, no history of malaise, joint pain, or low-grade fever, no history of shortness of breath or cough, no history of loss of weight or appetite, no history of recent onset of diabetes mellitus. Patient does not have any comorbidities, no surgical history, consumes a vegetarian diet, is not a smoker or consumes alcohol, no other habits, and no recent alterations in sleep cycle, no significant contributory family history. On summarizing the history, a 64-year-old male with no comorbidities, having dull aching, umbilical and epigastric pain for 25 days, jaundice with pruritus since 15 days, pale colored stool since 10 days, and non-bilious vomiting for the last 5 days. Moving ahead, on general examination, the patient.
Just stop here.
Yes, sir.
So, what do you think? What is going on?
Sir, from the history, we can probably the disease pattern is suggestive of obstructive jaundice because the sort of dull aching, vague sort of pain, um, and then gradually progressing jaundice, which was initially insidious in onset, not associated with any prodrome or any fever with chills. Patient does not even have any previous history of jaundice in the past or any history suggestive of gallstone disease. So most likely, sir, surgical obstructive jaundice likely to be malignancy at his
What are
age.
the more important, or rather, I would say, specific points suggestive of obstructive jaundice based on history, rather than the uh, certain things you have mentioned? What are
Sir,
more important or more specific features in the
sir,
history?
deepening jaundice, high colored urine, pale colored stools, and painless
And
progression,
pruritus. And
and
pruritus.
pruritus. Yes.
So I think the earlier you have mentioned they are the non-specific symptoms, right? Suggestive of obstructive jaundice. So
Yes,
this
sir.
patient is having obstructive. This patient is having jaundice. Okay, last around 25 days, right?
Yes.
And that is gradually increasing,
Yes,
right?
sir. Yes, sir.
And there is a pruritus, and now there is a vomiting. So why there is a vomiting for the past 5 6 days?
Sir, probably, sir, in this case, such a short history, outlet obstruction is unlikely. Maybe consumption of uh, analgesics, over-the-counter medication. Probably you must have visited a local
Mhm.
doctor, some sort of medication. Sir, this vomiting per se is unlikely related to the disease progression, sir. It's such an early stage, sir.
Okay. So you don't think this vomiting is related to the primary pathology causing
Yes,
jaundice?
sir. It's at such a early stage, sir, because such a short history. Unlikely to be obstructive, sir, in such a brief period, sir.
Right. And why it is non-bilious?
Sir, because there is probably distal obstruction in the extrahepatic biliary tree.
Yeah, it is obstructive jaundice.
Yes,
Right.
sir. Yes, sir.
Okay. Go ahead.
Right, sir.
And just enumerate what is the relevance of all those negative history you have mentioned. Just one by one, what you had in your mind while
Sir,
asking those history
sir,
in the
fever will,
context of current symptoms.
yes, sir. Fever will suggest cholangitis.
Mm-hmm.
Sir, abdominal distension suggestive of ascites. They can be associated liver disease or malignant ascites. So bleeding PR, we all know either if it's a or a malignancy of the duodenum may bleed. Even in CLD, all these symptoms may be present. Prodrome suggestive of viral hepatitis or any other viral cause of jaundice. Shortness of breath, cough can be again suggestive of metastatic disease progression. Or it can also
Is it
be,
really metastatic disease, shortness of breath or cough?
sir, pleural effusion, sir.
Rather, you just mentioned more common situation rather than uncommon, right? The
Right.
lung metastasis presenting with the dyspnea or cough as their manifestation is very uncommon. They are usually found on your staging workup on imaging, whether most likely on the CT scan rather than even on the X-ray chest, right?
Right,
So
sir.
presence of dyspnea or cough usually it suggests presence of underlying pleural effusion rather than lung metastasis per se.
Pleural effusion, yes, sir. Yes. Yes. And then no history of loss of weight appetite. It can be a part of the cancer cachexic process, sir. And also no history of recent onset of DM. Diabetes mellitus, sir, in certain pancreatic malignancies, it is noted that a recent onset of diabetes mellitus or change in regular sugars, requirement of more insulin or more oral hypoglycemic agents is suggestive of disease progression towards malignancy. So there's some literature which is
Disease
suggestive of
progression towards malignancy or development of malignancy. It is a
development of malignancy.
what disease will progress towards malignancy,
Chronic pancreatitis.
right? And how recent is the recent?
Uh, so recent means over the last 2 to 3 months.
Sure.
Pardon me, sir.
Are you sure about 2 to 3 months?
Sir, well, I'm not definite, sir, but that's
I
what.
think it is 1 year. Suppose
Okay,
you
sir.
develop new onset diabetes mellitus, especially in elderly patient, then there is a higher risk of developing malignancy in the next 1 to 2 years.
Right, sir.
So that is something I would say that is kind of predictor for early malignancy, right?
Right, sir.
And in the same context, now just tell me whether this obstructive jaundice, do you think it is a malignant in origin or it is a some benign etiology?
Sir,
Based on your history, can you just make out what could be the cause of? Matlab, can you divide into benign or malignant category?
yes, sir. There can be benign cause. There can be choledocholithiasis.
No,
Uh,
can be named. What are you suspecting? See, ultimately, all the causes they are easily benign or malignant. But
yes,
in
sir.
this particular case, based on history, can you just have some clues whether it is a benign process which is going on or whether it is a malignant one?
Sir, this looks more like malignancy, sir.
Reasons?
Sir, deep jaundice
Mhm.
and progressive, painless.
Deep jaundice based on?
Sir, on inspection, the patient was deeply
But you
jaundiced.
have not examined yet.
Yes,
We are just
agreed.
talking about based on your.
Sir, painless progressive jaundice associated with
Mhm.
pruritus, um, more likely at his age. It, choledocholithiasis is a possibility, but it, the history sort of points towards malignancy, sir. But you can always, choledocholithiasis is always going to be a possibility, sir. But patient does not have any previous history of gallstone disease, suggestive of any gallstone disease, any bloating, dyspepsia associated
See,
with.
you can have all the possibilities. Okay,
Yes,
what
sir.
is the you are talking about? What is more probable, right?
Yes,
So
sir.
can you make out or can you are not able to make out? So just simple answer. Whether
Sir,
you are
no.
able to not able, no problem. Okay, just
No.
proceed with the examination.
Yes, sir. Right, sir. So coming to the general examination, the patient is conscious and oriented, was conscious and oriented at the time of examination, moderately built and nourished, ECOG2 with a BMI of 25.5 kg per meter square, with a resting pulse rate of 82 beats per minute, with a blood pressure of 130 by 80 millimeters of mercury, afebrile at the time of examination, maintaining a saturation of 99% on room air with a breath holding time of 24 seconds. Icterus was present, no pallor clubbing, cyanosis, pedal edema. Sir, left supraclavicular fossa, there was no lymphadenopathy or no generalized lymphadenopathy otherwise. On abdominal examination, on inspection, the abdomen appeared flat. The umbilicus was central. There was a visible lump in the right upper quadrant of the abdomen, sir. There was no visible peristalsis or pulsations noted. Hernial orifices, no visible cuff impulse. Renal angles, they appeared normal, and the skull and spine examination also normal on inspections. On palpation, sir, the abdomen was soft, non-tender. There was a soft globular swelling 5 by 3 centimeters in size, palpable in the right hypochondrium, just below the right costal margin in the mid-clavicular line, and this was mobile with respiration. There was no other palpable mass in the abdomen, and there was no hepatosplenomegaly. The liver span was 14 centimeters in the mid-clavicular line, no free fluid on clinical examination, and on auscultations, the normal bowel sounds were heard. Digital rectal examination was also performed, where the perianal skin was normal, no sinuses, fistula, or hemorrhoids. Anal tone was normal with adequate squeeze. Finger glove was stained with pale colored stool, sir. No palpable mass or nodule was felt during DREs. Just briefly looking over the other systems, the respiratory and the cardiovascular system were also normal, and there were no focal neurological deficits. So again, looking at the summary after analyzing the history as well as the clinical examination, a 64-year-old male, ECOG 0, no comorbidities, having dull aching abdominal pain in the epigastric and the umbilical region for 25 days, jaundice with pruritus for 15 days, pale colored stool for 10 days, non-bilious vomiting for the last 5 days with a soft globular lump palpable in the right hypochondrium, just below the costal margin in the mid-clavicular line, which was mobile with respiration, and pale stools on distal rectal examination with no other organomegaly or hepatosplenomegaly and no free fluid in the abdomen.
So what is your interpretation of all these abdominal findings?
Sir, looking at the history as well as clinical examination with a definitive globular lump swelling, which is globular lump, which is the gallbladder, sir, most likely, in the presence of jaundice.
The most likely, or
It
you think
is.
it is
It is the
gallbladder?
gallbladder. It is the gallbladder.
Right. So you can simply in summary, you can simply mention that there is a palpable gallbladder.
Yes, sir.
See, what you find on an examination, they are the objective findings, but you have
Yes.
to interpret those findings, right? So
Yes.
when you are, I think, presenting your summary, you better mention your interpretation of those findings. Like you have mentioned that there is a globular swelling in the right subcostal area, right hypochondrium along the right subcostal margin. It is soft, right? It is globular. So what is that interpretation? So it is a palpable gallbladder,
Yes, sir.
right? So you
Yes.
have a patient with jaundice, pain abdomen. There is a pruritus, there is a pale colored stool, there is a pruritus, and then on examination, I think there is only one positive finding, that is palpable gallbladder, right?
Yes. Yes, sir.
Besides jaundice,
Yeah, sir. On
obviously.
clinical examination, pale stools on DRE, palpable gallbladder,
Yeah,
and clinical jaundice.
pale stools were there on examination, but on your history, but examination revealed one palpable gallbladder, which was
Yes.
not there on your overall real assessment, right?
Yes. Yes, sir.
So now, what is your overall interpretation and what is your differential diagnosis now?
Sir, in a patient with jaundice and a palpable gallbladder, it's unlikely due to gallstones. So most likely it's surgical obstructive jaundice. So I would.
Don't mention you are you are presenting in the reverse way.
Okay, sir.
You first mention the DD, then and you explain why it is so, rather than you just explain first and then you mention DD. Got my
Sir.
point?
Yes, sir. Yes. Sir, extrahepatic biliary jaundice most likely CA head of pancreas. It can be periampullary. It can be distal cholangiocarcinoma.
Mm-hmm.
and it can also be a hilar block, sir, with CAGB
It
causing
can be. What is the I would say high probability. In terms of
this
probability, what is the number one?
CA head of pancreas, sir.
So number one is C head of pancreas. Second,
Yes, sir. Second would be periampullary, sir.
second is periampullary. Third,
Third one would be distal cholangio. But
fourth,
and
fourth.
then s- CA neck of gallbladder with hilar block.
Okay. Anything else?
Sir, I think that would be it, sir, as far as my DDs are concerned, sir.
So basically, it is a malignant cause. Okay.
Yes,
So
yes,
there
sir.
is a malignancy which is causing all those symptoms and
Yes,
signs. Okay.
yes.
So that is the basic pathology. Now, in the malignancy, so there is no benign cause as such in this
No, sir.
particular patient.
Yes, sir.
You are not suspecting any benign cause. You are suspecting all malignant causes. And the number one is the C head of pancreas.
Yes,
Number
sir.
two, you mentioned periampullary carcinoma, then lower end cholangiocarcinoma, then CAGB neck causing hilar block.
Yes,
So
sir.
now, just what are the points in favor and against of each of these DDs in terms of your priority? Why do you think it is a C head of pancreas as a number one?
Sir, patient has got localizing pain in the epigastrium, and then jaundice, progressive, painless, and
Mhm,
sir, it's very difficult to segregate these malignancies just by clinical history and examination. But
mhm.
most of them will have overlapping signs with respect to history and examination, sir. But
Can you
more,
consider can you consider some other points besides simple history and examination? Because on examination you are not able to make out whether it is a
sir,
uh,
one can consider waxing and waning of jaundice, which is not there.
you can start from demographics. For example, the same patient you have mentioned, the patient is from somewhere in the Rajasthan,
Rajasthan,
right?
sir. Yes, sir.
The same patient who is coming from the Kerala, the same patient who is coming from the I would say UP or Bihar area or from Jammu Kashmir.
Yes,
So
sir.
with that background, can you make out?
Sir, yes.
Can you change your
Sir,
probability?
in the northern belt, gallbladder is more common compared to
Mhm,
pancreatic neoplasms. In Kerala, pancreas, CA pancreas is more common compared to gallbladder.
mhm. So I
So
think those demographic features are also equally important besides just symptoms and
yes,
sign. Got my point. So
yes,
whether it is a patient, a female patient, elderly female patient who has been having uh, pain abdomen in the past, who is from UP or Bihar area, right? Now she is developing jaundice for past month. Okay, it might be more possibility of carcinoma gallbladder, maybe from
yes,
the neck.
yes.
But in that case, what would be the finding of the gallbladder?
Sir, if it is, uh,
Is
uh,
distended gallbladder is distended gallbladder in CA neck gallbladder
sir,
is
CA
different
neck, it
from.
may be palpable, sir, but most of the times,
Mhm.
if it is a CA gallbladder, it won't be globular and soft and palpable in the early stages. Most likely, it will become a hard mass later on, sir.
So it would be a mass rather than palpable gallbladder,
Yes, sir. Yes,
right?
sir.
A
Yes,
palpable gallbladder means the gallbladder is otherwise normal except that it
yes.
is distended. It may be tensely
Structurally
distended.
supple with the distal obstruction will
It
cause
may
this
be
problem.
tensely distended. It may
Yes,
be relatively soft and supple, right?
yes, yes, sir.
Okay. But if there is a mass at the GB neck, which is causing obstruction and causing it become making it a mucocele kind of thing, right?
Yes,
Rather than gallbladder mass per se. So you can
yes,
have a palpable gallbladder, but in that sense, it would be a more tense,
yes, sir.
right?
Yes, sir.
So this will also be a situation in case of your obstruction lower down, maybe in the head of pancreas.
Right,
In
sir.
this periampullary carcinoma, what happens? There is a pressure buildup is there, and then because there is a small growth at the ampulla, it may slough out, and then in between it decompresses, right?
Yes,
But in case of CA head of pancreas, it is a firm, ongoing, continuous obstruction at the lower end. So gallbladder would be again, it become tense, I think you must have seen during the Whippers procedure until
Yes, sir.
unless it is stented. So even if gallbladder is not palpable, gallbladder again remains the distended and tense.
Yes,
Sometimes it is so much so that it can reach even till the right iliac fossa, right lower abdomen.
iliacus.
And-
Yes.
Okay. So number two, first you have mentioned CA head of pancreas. How can you explain vomiting now? Can you explain again those vomiting symptoms? Because now you are saying it is a malignancy.
Sir, yes, CA head of pancreas in advanced stages tends to involve the duodenum, which can cause features of gastric outlet obstruction. In that scenario, vomiting is explainable, sir.
Okay. So now you can explain that symptom also, no?
Yes, sir.
Second DD was periampullary carcinoma, right?
Yes, sir.
So again, the points in favor of which kind of periampullary carcinoma? What do you include in the periampullary carcinoma group?
Sir, any mass arising from 2 centimeters from the ampulla, which can be the duodenum, pancreas, ampulla, or the ampullary complex itself, and distal CBD. So all that will be part of the periampullary carcinoma complex.
So do you think it is a periampullary carcinoma?
Sir,
You have mentioned yes as a second number,
it can be, but statistically, CA head of pancreas will take precedence.
and then lower end cholangiocarcinoma.
Yes, sir, that will be again. I statistically, even though CAGB is more common than distal cholangio, sir, but male patient with no preceding history of any gallbladder issues. That's why I just placed cholangio above gallbladder. And since it's a globular swelling, soft, supple, so I thought more distal obstruction would be more favorable as a differential rather than just placing CA gallbladder above distal cholangio. However, it's clinically difficult to segregate distal cholangio from periamp just by history and clinical examinations, sir, because they will present with similar feature complex as far as uh, clinical history and examination is concerned, sir.
What could be the more, I would say, symptom suggestive of cholangiocarcinoma, which can even begin even before your jaundice, clinical jaundice?
So, is it pruritus? Pruritus may sometimes precede jaundice. In
Right. Can it be hilar cholangiocarcinoma, cracked skin tumor?
hilar cholangio, sir. Yeah, it unlikely, sir, because the gallbladder is palpable in this case. So hilar block will be higher up,
Hmm. Okay.
unless the hilar block involves the uh, duct or the neck of the gallbladder. Then in that
Can it
scenario,
be
gallbladder.
okay? Can it be chronic pancreatitis?
Yes, chronic pancreatitis with a distal CBD narrowing or stricturing, significant stricturing can cause these symptoms as well, sir.
Yeah, that can cause or that can be a
That
possibility
can
in
be,
the
but with no preceding history of any epigastric pain, history of pancreatitis, unlikely, sir. मतलब,
He
de
is
novo
alcoholic.
presenting with such an extreme scenario, unlikely, sir.
Is he alcoholic?
No, sir. No habits, sir. Not even smoking, no alcohol consumption, nothing.
Right. So even if it is chronic pancreatitis, uh, the presentation is because of the complication of malignancy rather than chronic pancreatitis per se.
Yes, sir.
Right. In this situation.
Yes,
Okay.
sir.
How will you proceed now?
Sir, we would go ahead and do the basic blood work that we had done. Patient had some previous blood works which was done outside, and then there was basic set panel which was done here, including hemoglobin, which was around 13. Total counts were within normal limits. Platelets were normal, creat was normal, and sodium potassium were also normal, sir. Total bilirubin direct 24.2 and 21.8 respectively. AST
So
80.
just want to ask you, if you see such kind of patient in an OPD, what
Yes, sir.
will you do?
So in OPD basic investigation, I would first like to get a blood work and ultrasound just for screening.
Don't you want to admit the patient?
Yes, sir. Definitely.
The patient wants treatment, not investigations. As you have mentioned, patient was having vomiting for the past 3, 4, 5 days.
Yes, sir.
right? So patient first needs treatment,
Yes, sir.
then diagnosis,
Yes, sir.
then final management.
Yes, sir.
So I think if you start with the that you will get the investigation that is more of a academic theoretical exercise, but you have to look at from the practical point of view also,
Yes, sir. Agreed, sir.
right?
Yes, sir.
Because you are managing a patient,
Yes,
right?
yes,
Okay.
sir.
Hmm. So
CA
you
nine.
will get these blood investigations.
Yes, sir. CA 99 was also done. It was 141, sir, and our mileage was normal.
What is more significant thing and relevant thing in this investigation chart? Leave
Sir,
about 19.9 now at present.
sir, features of obstructive jaundice.
So it is
Uh,
there, it was there on clinical examination also.
yes, sir.
It was based on your this thing examination, but it is confirmed now. But
Yes,
what
sir.
is more than that?
Sir, subclinical cholangitis, OTPT is slightly raised. Alphos is also raised.
See, look at the total bilirubin level. Do you
Yes, sir.
think is it suggesting something as you were suspecting?
Yes, sir. It is indicative in that direction only, sir.
Right. So there are two things.
Yes,
The
sir.
LFT is suggesting of obstructive jaundice,
Yes,
right?
sir.
Based on your direct
Yes,
bilirubin is significantly raised, more than 50%. Alphos is raised.
yes, sir.
Gamma GT, it is not there. So
Not
it
that.
is confirming that patient is having obstructive jaundice. First.
Yes, yes,
Second, it is a very high bilirubin. Okay, it is 20 plus. Again, it is suggesting that it is some malignant process which is causing
yes,
this presentation.
yes, sir.
Right.
Yes,
Third, suppose even if it is a malignant process, then it indicates or suggests that you have might have to change your management plan because your bilirubin level is very high.
yes, sir.
Okay.
Yes, sir.
And with regards to your cholangitis part, what you were saying,
So subclinical cholangitis, OTPT is raised. Patient, however, is afebrile, no
what is
tachycardia.
subclinical? How you define and classify cholangitis? What is subclinical cholangitis?
Sir, patient does not manifest clinical features of cholangitis like fever, chills, tachycardia.
How do you
Feature.
diagnose cholangitis? What is the criteria?
Sir, it is the uh, cholangitis, sir, right upper quadrant pain, fever, jaundice, fever with chills, the Charcot's triad.
This is the classical triad, right?
Yes, yes, sir.
Okay, but in how many patients this triad is present?
Sir, the percentage is there, but I don't remember it at off of my head. But there is a percentage which they have stated. I don't remember it clearly, sir.
See, the current criteria you use to diagnose cholangitis is the Tokyo guideline.
Tokyo guidelines, sir. That
So
is the
either you suspect or either you confirm. So
yes,
I
sir.
don't think there is a subclinical cholangitis.
Right, sir.
ठीक है? You
Okay,
can
sir.
have a suspicion of cholangitis
Right,
based
sir.
on certain criteria. ठीक है ना? So it is the presentation, it is the imaging, and it is the blood investigations. So
Yes,
we don't have any CRP at present. TLC
yes,
is more or less
normal.
normal. If you
Yes,
take
sir.
11,000 as a cutoff, then it is less than that. If it is 10,000, initially it was marginally raised, right?
Yes,
Only
yes,
thing is the differential is raised. Neutrophils are predominant, 85, 80% plus. Then we don't have any CRP. And
yes,
then OTPT, they are slightly raised, right? But jaundice is there. So jaundice is there. Obstruction, as of it, we expect it is there. But inflammatory markers, they are not raised. Clinically,
yes.
there is no fever.
Right, sir.
There is no leukocytosis.
Yes,
So
sir.
at the most, it may be a suspected cholangitis rather than confirmed cholangitis.
Yes, sir.
Okay. What is the other investigation which is more relevant and significant? CA 19.9.
Yes, sir.
So in the
140.
presence of jaundice, is it really significant?
No, sir, because in obstructive jaundice, we really can't interpret CA 19.9, sir.
Okay. So is there any other method,
Uh,
other way to uh, assess its significance?
Sir, once the jaundice is taken care of either by stenting, then only we can, once the jaundice comes down, maybe we'll be able to do a prognostication based on CA 99, but not in the current scenario, sir.
Any other investigation here? that becomes important in terms of management?
Sir, I would like to get an
What
look.
about albumin?
Yes, albumin is 3.6 and INR also is relevant here if we are planning any
Mhm.
intervention.
Right.
Yes, sir.
Okay. So albumin is maintained from 12 to 23rd,
Yes, sir.
right?
He is physically preserved, sir. Yes, sir.
He is physically preserved.
Sir.
Okay. Next.
Sir, USG abdomen, which was done outside, sir, suggestive of hypoechoic area in the para-aortic region, 28 by 24 millimeters, which was a lymph nodal mass according to the ultrasound report. Normal size liver with cyst in the right lobe. Prostatic enlargement with insignificant residual urine. Normal study of gallbladder. Visible pancreas, clean left kidney and urinary bladder. So then patient.
Go back.
Yeah.
So if you see this ultrasound report, do you think it is a complete report or you want some other information?
No, sir. Actually, the report is incomplete. It was written on a paper. He'd gotten it done at his village only. So it
Okay.
was
So
an
what other information you expect from video?
IHBR comment on intrahepatic biliary radical dilatation. The definitely the gallbladder is distended on clinical examination. Comment on that.
Mhm.
Or no, there's no comment on any free fluid in the abdomen. The status of the liver. All that is missing, sir.
Not only it is the intrahepatic, you also have to see the extrahepatic part. Na?
Extrahepatic, sir. Yes,
Stage of
dilated.
CSD, CBD,
And
right?
pancreatic duct.
ED, if it is possible
Yes,
to see,
yes, yes, sir.
right?
Yes,
Then
sir.
you have mentioned ascites, any other lymph node, because they have just mentioned what is the most obvious finding. So
Yes,
they
sir.
have not looked for. So this becomes a clinical correlation, right? They always ask, they always write on the this thing, investigation report, clinical correlation. So this is
Yes,
not correlating with the clinical picture of the patient.
yes, sir.
So this is incomplete. So just
Yes.
going ahead now at this stage, what is the next investigation you will get? Forget
Sir,
about what you actually have in your hand.
I would like to get a CCT, sir. CCT, the abdomen.
Okay, you want to have a CCT abdomen
Yes, sir.
for
Sir, it would give us a more comprehensive, detailed picture of the abdomen, sir. We are suspecting carcinoma head of pancreas.
Mhm,
Pancreatic protocol CT will give us more detailed information about
mhm.
the hepatopancreatic biliary complex. We'll be able to ascertain the site of the block and the extent of the block. We'll also be able to rule out metastasis to a certain extent in
Basically,
the.
you want to have a CT scan to confirm your diagnosis,
Yes, and
to
plan of
assess
management.
its resectivity,
Yes,
if it
sir.
is so, and then
Yes,
you want to have a final staging,
yes.
right? So you want to have a CCT chest also at this stage, along with CT abdomen.
Sir, an HRCT chest would also be good, but X-ray as a screening measure is usually done. But
At
ideally,
this
HRCT,
stage,
pardon me, sir.
at this stage.
Not at this stage, sir. Metastatic workup, if needed, we
Hmm.
can get it done.
So you first want to confirm the diagnosis.
Yes,
So
sir.
do you have CT scan with you?
Yes, sir, we do, sir.
So first
MRC is
describe
good.
CT scan.
So this is the video of the
Hmm.
CT. This is the arterial phase. You can see, sir, there is a hypo dense mass
You
of the
first
head.
run the video and then describe the findings, and all the relevant findings.
Right, sir. It's done, sir.
Yeah. Then now describe all the relevant positive findings on
So
CT scan.
on initial
So
look,
this is the arterial phase, है ना? So you
yes,
might
sir.
be having the other phases also.
Yes,
Would have
sir.
been delayed. Okay.
Yes.
So first you
So,
describe findings on arterial phase.
so on the arterial phase, bilobar IHBR is visible. There is a replaced right hepatic, sir.
No,
Uh,
just show also. Then
then there's a replaced right hepatic, and then there's a hypodense lesion in the head of pancreas. The rest of the pancreas illuminating is
see, you have started from IHBRD, so you continue with the extrahepatic.
right,
The
sir.
CLP is dilated, CBD is
Yes,
dilated in
yes,
lower
yes.
end.
Extrahepatic biliary apparatus is dilated, sir.
Yeah,
And
so
even
that will
the
be a complete finding, no?
yes, sir. And the PD is also dilated, sir.
What about GB?
GB is dilated, sir.
It is distended, no?
Yes, distended.
So there is a large hypoequic mass in the head of pancreas, and
Yes.
the CBD is dilated till lower end.
Lower end,
It's
sir. And there's
blocked
an
by the mass.
abrupt mass at
Hmm.
the head of pancreas,
Hmm.
hypodense. The rest of the pancreas is uniformly.
Okay. Other findings: lymph nodes, ascites, liver SOLs.
Sir, there is no liver as well, sir. There is no ascites. Lymph nodal mass, sir, it's difficult to comment. There's no obvious lymphadenopathy on this CT scan.
Remaining phases. What about the resectability? Now you can see a mass is there. Now what is the next aim of assessing the imaging?
So we have to look at the resectability.
So how will you assess the resectability?
First of all, we have to look at the portal venous phases as well, sir.
Hmm.
Uh, we just go ahead. So arterial is done.
So just tell me what is the resectability criteria in CA head of pancreas?
Sir, it should not be the SMA. Should not be. It should be free, and the SMV portal venous access should also be free of tumor. Uh,
Free in the sense,
Sir, in the sense that it should not be involving. So for the venous, it's different. It's less than 180 with no contour abnormality, or greater than 180 with contour abnormality, making it borderline resectable. Same goes for the vessels, sir. But these days, if you're able to resect the vein and reconstruct it, so that has sort of taken that out of the window. And so, based if the reconstruction is possible, then the mass becomes
see,
resectable
you have to
and no
assess for
metastasis,
resectability means ki it is clearly resectable, it is borderline resectable, or it is unresectable.
unresectable.
Right. First, you
Yes.
have to जो है, categorize the disease.
Mhm.
Then, suppose it is clearly resectable, then it is a different thing. It is a borderline resectable, then you have to plan accordingly, or it is totally unresectable because of the locally advanced disease, then it is a different thing.
Yes, sir.
So first, you have to
Sir,
decide whether
on the
this,
arterial phase, it looked resectable. Uh,
you have to see the other phases also, right?
yes.
So
Yes.
whether there is a abutment, there is a encasement, right? What
Yes,
is
sir.
the status? What is the length of the vein which is involved besides being there is an encasement or abutment? What is the status of gastroduodenal artery, CHA, right?
Yes.
What is the extent of mass? Whether it is going behind, it is involving IVC, renal vein or not, right? So this is the local assessment.
Yes, sir.
Then you have to look for the distant. Any distant metastasis in terms of nodes along the celiac axis, CHA, intra-aortic, para-aortic. Then you have to look for the liver metastasis. So
Yes.
you can stage the patient in the other way around, like it is a TNM. So you can start with the MNT. You have
Yes,
to
sir.
first rule out the distant metastasis. Then you have to assess the loco-regional condition disease, then you have to assess the primary. So the purpose of overall imaging assessment is to define whether this patient is clearly resectable, upfront surgery is required, whether it is a borderline, do you need to have a neoadjuvant therapy, or it is clearly unresectable,
Yes, sir.
or it is a metastatic disease per se.
Yes, sir.
Got my point. So describe all those findings with the aim to have such kind of assessment. Got my point.
Yes, sir.
Okay.
Sir,
So what is next?
portal phase.
Okay, describe. You have video, so just describe. We have just 10-15 minutes more. Keep on describing.
The same as a bilateral bilobar HBR, extrahepatic biliary is also dilated. The portal vein is seem to be formed. Sir, adjacent to the mass, there appears to be an interluminal thrombus in the main portal vein trunk, sir. If
Right. So
Yeah.
that's why I'm telling you कि you have to make the final assessment once you have gone through all the phases of imaging, not just based on one
Yes, sir.
article, right?
Yes, sir.
So describe again this important finding.
So on the portal venous phase of the CT abdomen, we can see that there is bilobar IHBR. The
ठीक
hepatic
है?
veins appear to be normal. Then the right and the left portal vein are coming together and coalescing, forming the main portal vein trunk. The
Go slow here. Hmm.
main portal vein trunk at this point right here, sir. There is a thrombus within the main portal vein trunk. adjacent to the mass.
So is vein infiltrated by the mass, or it is a thrombus which is separate? What do you think? What is the cause of this thrombosis? And
So
any other findings? Now you have seen there is a thrombus in the portal vein. Any other positive findings in
uh,
this area? Are there collaterals? Are there features of portal hypertension?
so no features of portal hypertension, sir.
Like,
Pardon me, sir.
like,
No, sir. No collateralization around the main portal vein trunk, sir. No portal
Mhm.
cavernoma, nothing. No ascites. The liver also appears to be normal.
Spleen.
Pardon me,
Wait
sir.
a minute. Wait a minute. Spleen. What about spleen?
There's no splenomegaly, sir.
Sure.
Looks.
Go back on the imaging. Go cephalate. How you assess splenomegaly on CT scan?
eh, it was not palpable on clinical examination, sir. That's
No,
what I
but
meant.
we are not talking about the imaging, right? Right. When the liver stops, yeah. Wait. So still you can see some portion of the spleen.
Here, sir.
Go back. Yeah. Go back. Cephalate.
Sir, actually, the whole video plays again, sir.
Okay.
Actually,
So you can still see some spleen when the liver you cannot see. You expect some hepatomegaly because of the obstructive jaundice, but still spleen is there. It means some degree of most likely patient is having mild splenomegaly.
right, sir.
But right, but there are no collaterals, and this thrombus is extending in the portal vein, right?
Yes, main portal
Not
vein.
below the splenic vein portal vein conference, either in the
Conference.
splenic vein or
It's just limited to the main portal vein trunks.
okay. So is it infiltrated by a tumor, or this thrombus is unrelated to tumor?
So most likely it is a tumor thrombus only, sir.
Is there any irregularity in that area?
Sir, it is just lying adjacent to the mass. Here, if we take a look closely,
Go slow, go slow.
right, sir, here,
Just
it,
wait, wait. This is
yeah,
the thrombus which is starting, right?
yes, sir, yes, sir.
Okay. And just again, go ahead slowly. Wait.
Here, sir,
Yeah. Right. So I think there is a mass lesion,
yes, sir,
and there is a portal vein which seems to be
involved, sir.
involved,
Yes,
and
sir,
there is a thrombus,
yes, sir.
right? So now, how will you classify this thing? This is resectable, this is borderline resectable, or this is unresectable.
Sir, if there is an adequate length that we can sacrifice an anastomose either by graft or a native graft that we can harvest, it becomes borderline resectable, sir.
So, okay,
With respect to, we've also done an MRC for
right.
this patient, sir,
Why MRCP?
just to look at the extrahepatic biliary tree, sir. And
But it is you can see what is the advantage of having MRCP once you already have CT scan in your hand, and that is a good quality CT scan, which
yes,
is
sir.
showing there is a mass in the head of pancreas,
The
which is
smaller lesions are better visualized, but this is a big enough lesion.
it is already there, na? So what is
Yes,
the
sir.
added advantage of having MRCP? It is a different thing that the patient came to you with the MRCP,
Yes, sir.
then you got the CT scan, but
Yeah.
ultimately you got the CT scan.
Yes, sir.
But
That's
having an
the case, sir.
MRCP after CT scan, I think that is not going to help you
Helps.
much.
Yes, sir.
So what is the next thing you would like to do in this patient?
I would like to get an upper GI endoscopy and stent the patient because of the high
Upper
jaundice.
endoscopy for.
Stenting, sir, ERC and stenting.
So I think we have 10 minutes. After 5 minutes, we will stop and we will take up some questions so that we can have some discussion over the queries raised by some other students, right? So what is the aim of getting upper GI endoscopy? You want to?
Pardon me, sir? I couldn't hear you.
What is the aim of getting upper GI endoscopy? What is the purpose? So,
Sir, patient has vomiting. So with upper
okay.
GI endoscopy, we'll be able to clinch whether at all there is duodenal infiltration. That's one. And also at the
Right.
same time, we'll be able to do a ERC and stent, sir, because of the jaundice.
MRCP is different and ERCP is different. You will send either for upper endoscopy. Now I'm asking what is the purpose of having. So one is the gastric outlet obstruction, and second you want to rule out the gastroesophageal varices because splenomegaly is there, portal vein is involved,
Yes.
right?
Yeah, right, sir.
Okay. And second is the ERCP. So what is the purpose of getting ERCP?
Sir, it will bring down the jaundice, sir.
Anything else? Why
Improve
do you want
the
to bring down the jaundice?
improve the patient, sir, symptomatically, and give us time to evaluate, and if required, patient, if neoadjuvant is to be given to this patient, it will help us buy time, sir.
So there are two things. First, you want to have the side wing endoscopy and to get the biopsy report.
Yes,
Right.
sir.
Given the situation when bilirubin is very high, more than 20, 22, then there is a portal vein thrombosis, which is a locally advanced disease. Most
Yes,
likely, this patient will require neoadjuvant therapy. You are not going
yes.
for the upfront surgery.
Upfront resection, sir.
So, rather than saying it is a symptomatic relief, you require the bleed drainage for this purpose to start the neoadjuvant therapy.
Yes, sir.
Right. So
Yes, sir.
symptomatic relief will be there as a part of your drainage, but you will get the biopsy because you will get the side wing endoscopy and you need biopsy to start any neoadjuvant therapy. At the
Yes, sir.
same time, we will do the stenting to bring down the jaundice because neoadjuvant therapy cannot be started once
Started at such a high level of jaundice, bilirubin.
right. So there are two different purposes. But what is the final plan? What would be the final plan?
So the final plan would be to stent the patient, start the patient on neoadjuvant, uh, and then
Mhm.
follow up the patient, look for how the cancer behaves
Okay,
biologically.
what kind of sending you will okay, you are sending patient to gastroenterologist and he will ask you, should I put a plastic stent or any other stent? What will you suggest?
Plastic stent as of now, sir.
Why not metallic stent?
Metallic stent is more like a permanent stent, sir. If you're not planning to operate on the patient, then metallic stent will be the way to go, sir.
What about short metallic stent? What is the advantage of metallic stent over plastic stent?
So occlusion rates are lower in metallic stents versus plastic stents.
So there are two different situations. One situation is that you have a resectable disease with very high jaundice.
Yes,
You
sir.
want to decompress the system and you expect patient to get operated in a short period of time, maybe after 2 weeks or 3 weeks. And there is another situation when you have a locally advanced disease. You want to put the patient on neoadjuvant therapy, and it is expected that there are few months before you reassess the patient. So what happens if you just put the plastic stent? They have a very short, I would say, the half life in terms of blockage, 2 to 3 weeks. So maybe after 2 to 3 weeks, you have to ask the stent change because of the stent block cholangitis. There is a possibility.
Yes, sir.
So I would rather prefer putting a short metallic stent because it will be a more definitive.
Vishal sir, good morning,
Hello.
sir. Sir, good morning.
Just finishing.
Hello.
Good morning.
Sir, Dr. Vinay.
Hi.
Hi, sir. Sir, actually, we are running out of time, sir. We have
Yeah, it is 3 minutes
five
more,
minutes,
I
sir.
think.
Yeah,
Three
5 minutes.
minutes more.
Yes, sir, please, sir.
5 minutes more. Okay, we will just close down and we will take up some question if you allow.
Yeah, sir,
Otherwise, we
please,
will
sir.
just finish minutes, right?
Yes, sir.
Mhm.
Okay, sir.
Sir, Atul has
So,
asked.
what is the final plan? You have already mentioned.
Yes, sir. The final plan is to stent the patient. As you suggested, a metallic stent would be a more sensible choice here. We can stent the patient, then send the patient over to medical oncology, give a trial of neoadjuvant chemotherapy, and look for the response. And then we'll be able to ascertain the response as well as the biology of the tumor and plan further management after
Okay,
reassessments.
last question. Do you want to get the PET CT scan?
PET can be done, sir. In this scenario, PET can be done.
PET can be done or PET should be done
PET
in
should
this
be done.
situation.
PET should be done.
Purpose
Rule out metastasis.
rule out metastasis. Okay, because I think it got disconnected and reconnected. We lost some questions in chat box.
Sir, somebody is Atul has asked. There is pain in epigastrium and paraumbilical region. So will it be painless or painful? So, sir,
Yes.
it wasn't a very specific pain. The pain was dull aching, some more like a discomfort rather than a pain. So I would probably call it painless progressive jaundice, sir, because I what would be your thoughts, sir? Because it was more like a discomfort according to the patient rather than a severe pain.
No, it's not a classical disease. What happens when the patient has deep jaundice?
Sir, you're unaudible, sir. Thank you, sir.
Suddenly, dear Vishal sir, to everyone finishing. Thanks everyone.